Welcome, guys. Today we'll be talking about the blood supply to the scaphoid, a little bit about scaphoid non-union and which type of fracture, at which level of the fracture of the scaphoid does non-union occur usually, and also a little bit about which type of scaphoid fracture we treat non-operatively and operatively. Okay, coming to the introduction, the scaphoid is the most commonly fractured carpal bone. 80% of the fractures are through the scaphoid waist, where the remaining 20% are either through the proximal pole, the tubercle, or more distally towards the distal pole area. An interesting, not so. This is with regard to traumatic AVN of the scaphoid. With regard to idiopathic AVN, it's a disease called Prizer's disease, where there's idiopathic AVN of the scaphoid without any prior history of trauma. It is a rare condition, and yeah, but it's been documented and it exists. So, coming to the anatomy, the scaphoid is the most radial bone in the proximal row of carpal bone, which consists of the scaphoid, lunate, triquetrum, and pisiform. So, the most radial of those is the scaphoid. It represents the flow of the anatomical snuff box. So, if there's tenderness at the anatomical snuff box, you can suspect a possible scaphoid fracture. You get like a scaphoid view where whole arm like this under the X-ray view, and you ulnar deviate, and you get a PA view. So that will be the scaphoid view. That's how you identify a scaphoid fracture on X-rays. Usually, radiographically, we don't see scaphoid fractures initially during the acute phase. The fracture line becomes more demarcated after a week or so. If you want an immediate, if you want like to detect an undisplaced scaphoid fracture immediately, then we probably have to get an MRI, which is the most sensitive investigation to detect the fracture line. Coming to the parts of the scaphoid, it has a tubercle from this. So this is the volar aspect. So the tubercle, the dorsal aspect. Dorsal view, volar view. This will be the tubercle. This will be the distal pole. This will be the waist. There's no anatomical definition for the waist, but it is just a fracture through the middle of the scaphoid, which is considered the waist area. And this will be the distal pole. Sorry, proximal pole. Proximal pole, distal pole, tubercle, waist. Coming to the next slide. As you can, it has 5 articulations. More distally it articulates with the trapezium and the trapezoid, two bones here. Medially it articulates with the lunate and the capitate, and more proximally it articulates with the radius along with the lunate. So the lunate and the scaphoid articulate with the radius. So the blood supply of the scaphoid, the entire blood supply is through the radial artery and its branches. The dorsal carpal branch of the radial artery enters through a foramina at the dorsal ridge. So it enters through from the lateral side of the scaphoid, and it enters at the level of something called the dorsal ridge at about the 1/4 3/4 junction. So 1/4 being the more distal bit, and 3/4 being the distal bit. So proximal bit. So 3/4 proximal and 1/4 distal junction is where the blood vessel enters, and everything from this line which I am drawing with the mouse below is supplied by the dorsal carpal branch of the radial artery. So the entire proximal pole, as you can see, has a retrograde blood supply. So it enters more distally and comes proximally. So this is a retrograde blood supply, and it entirely depends on the intraosseous blood flow. So you can imagine a fracture here. There won't be any blood supply to this region if a fracture line comes through this. I'll show you better with diagrams in the next few slides. So in addition to the dorsal carpal branch of the radial artery, which provides 80% of the blood supply, there's also a superficial palmar branch of the radial artery, which comes volarly. As you can see, it supplies only the distal portion and the tubercle. So distal pole and tubercle, and provides 20 to 30% of the blood flow. It either it comes directly from the radial artery or from the superficial palmar branch, but usually from the superficial palmar branch of the radial artery. So as you can see here, the superficial palmar branch supplies this region, which is the tuberosity and the distal pole area, and also supplies the waist a bit with these small branches coming through. Whereas the other branch of the radial artery The dorsal branch supplies the waist, a little bit of the distal pole and the entire proximal pole. So you can imagine a fracture line which runs through here. The blood supply to the entire proximal pole will be cut off. So you can see why there's a higher risk of avian influenza. It's just an interesting point. So rule of 70 for scaphoid. 70% of all carpal bone fractures are scaphoid fractures. 70% of the blood supply is by dorsal branch of radial artery. And 70% of fractures occur through the waist of the scaphoid, and 30% of scaphoid fractures tend to unite. So this is the rule of 70. Just an interesting point. Mechanism of injury. So it usually occurs when the wrist is extended and there's a heavy load based on the wrist with the radial deviation, with the more load on the radial palmar side. So the proximal pole locks into the scaphoid fossa of the radius, and the distal pole moves excessively dorsally, resulting in a fracture. So it's caused by it's caused by severe hyperextension and slight radial deviation of the wrist. So the Mayo classification. So distal tubercle fractures type 1, distal articular surface fractures type 2, distal third fracture is type 3, middle third fractures type 4, and proximal third fractures type 5. So from the previous blood supply diagram that I showed, which do you think has the most risk of avian? Proximal third fracture or type 5 Mayo classification. So treatment. So non-displaced stable fractures are treated non-operatively, whereas displaced unstable fractures usually are treated by operative treatment. So this is a good diagram showing how as the fracture line moves more proximally, the union rate decreases. You can see here tuberosity and distal pole fractures usually completely unite most of the time. Waist fracture, the most common type of fractures. High rate of delayed and non-union. So what fractures do we treat non-operatively? Scaphoid tubercle fractures, undisplaced acute scaphoid waist fractures. By what I mean by undisplaced is undisplaced or less than 1 mm displacement. Anything more than 1 mm displacement should be treated operatively. And pediatric scaphoid fractures. Indications for surgery: displaced fractures, obviously, and scaphoid fractures associated with perilunate fracture or dislocation, and undisplaced fractures of the proximal pole. So even if at the proximal pole fracture is undisplaced, it's better if we treat operatively. And also any fracture at the level of the waist which is displaced more than 1 mm, we treat operatively.